My name is Neil Halpern. I'll be talking about taking a comprehensive approach to patient-centered care in the ICU. If you're interested in the longer version of this talk, I was honored by Project Dispatch to do the webinar for them in December, so that's posted on the SCCM website. I deal with various vendors, none of which have anything to do with this talk. So what is patient-centered care? The formal definition is the delivery by the ICU team of the right care right now to achieve optimal patient outcomes. I always thought that was a very restricted definition. Patient-centered care is really much more. Patient-centered care implies the delivery of a positive ICU patient and family experience. And there are many well-known approaches, which I'm just going to go through very briefly. The ICU needs to develop a proper culture and team, enhance ICU communication skills, mentor staff on customer service, include patient and family on rounds, open visiting, staff debriefing meetings, early mobility, end-of-life mementos, some of which we just heard about, and quantitative outcomes research. But really, it's more than that. And here's our staff interacting with the patient and the family, and then things happen and the staff gets all frazzled. There is no way a frazzled staff can actually deliver anything remotely close to patient-centered care. As a staff gets frazzled, the family gets frazzled, the patient gets frazzled. So what else is needed for this process? Patient-centered care requires a content ICU staff working within a positive and thoughtful ICU environment. It cannot happen if the ICU staff is not happy and is unsatisfied, and if the ICU environment does not address patient, family, and staff needs. So this is a very important element. So what we need to have is a happy staff. That happy staff could deliver patient-centered care. When I told my graphics designer I needed something, she said, I got this covered. Okay, so we're going to look at patient-centered care through the prism of design and technology. Let's start with the front door, the signs, the holes in the walls of an ICU. We're going to look at pictures from 3 different ICUs. These are all SCCM award-winning ICUs, and it includes the ICU where I work at Memorial Sloan Kettering, the ICU at Emory Neuroscience Unit in Atlanta, and the ICU in Utrecht Medical Center in Utrecht, Holland. So the front door is actually very important. This is the way the front door looks at Memorial, and one has to have a very welcoming front door. And this is one of the front doors in Utrecht. Utrecht has, in fact, 4 different pods, and the artwork on the right, each pod has its own artwork. Holland has many beautiful areas, and artists were contracted by the hospital to design 4 different hallways, each reflecting the magnificent nature vistas of Holland. In Memorial, we also added along our hallways digital cinemas. So we have these in the ICU waiting room, and we have these along the ICU hallways. And these are magnificent displays. They're very large. They have surround sound. And every half hour, another video plays. And you see people gathering. We have very aggressive early mobility program, and the patients like schlepping their ventilator and getting to the next digital cinema. They stand there, they regroup with the staff, and they keep going. And you see a lot of consultations going on by the beach, by the waterfall, by the snow. Signage. You know, you walk around this place here, I'm not sure, maybe all of you could figure out where you're going. I don't know, I feel like I'm going in circles here, as in many conference centers. Very large ICUs have the same issue. So in this make-believe ICU with 4 pods, we have a family member on the bottom looking to find their loved one. And there are all kinds of signs, and none of them are too positive, and they can't figure out where they're going, and they get very hysterical, and they finally leave, and they give up. So you have to have good signage. As we designed our ICU, we spent hours with the signage vendor trying to design signs that would send people, staff, families, logistics, anybody where they have to go. And it was very sad that after hours, after we opened, the signage still didn't work. So a year later into the ICU, we redesigned all the signs, taking into account family members, staff, doctors, nurses, and so on, to get the signage right. So in this circumstance, in fact, there's a kiosk, and the hospitals are starting to install these, where you simply type in where you want to go to the kiosk, a printout is given to you, and you go where you got to go. And certainly that's very fancy, but proper signage will do the trick. Waiting room, very important element in the ICU. So this is our make-believe waiting room. We're going to focus first on the left side, and we have chairs. So we and others have designed waiting rooms similar to first class or business lounges at airports with pseudo-privacy. So there are various areas that give a feeling of privacy for families. In our ICU, we've installed a social work office. I initially thought this was crazy. It's not crazy. The social worker takes the temperature of the waiting room, engages with the families, the door is open except when somebody's in, and we now have 2 full-time social workers working in the waiting room and covering the ICU. It's phenomenal. We have a consultation room right in the waiting room, meet with families and doctors. We have a nutrition area. We don't have what we'll see Utrecht has, lockers, long-term sleeping accommodations, and here we have a visitor hallway into the ICU. We'll come back to the hallway on the right later. And this is what the waiting room looks like at Memorial. We have volunteers. Memorial has over 1,000 volunteers on staff. It is amazing. We have volunteers 6 days a week in the waiting room. They are in service. They could bring families in and out, and they're really great for people to talk to. This is the ICU waiting room in Utrecht, where they have private areas where people could sit and eat. And this, we're back at Memorial. The consultation room has a table, chairs, of course, a whiteboard. Many families want to understand what's going on with their loved one. And we also have a 24/7 translation system in the consultation room itself. Back to Holland, this is the long-term accommodation rooms in their waiting room. You have to have a lot of space to do this. New York doesn't have this kind of space. In Holland, this ICU was built on the roof of a very large hospital. If they needed more space, they just took more and more roofs. So they were able to do really great things. Let's come back to the hallways of the ICU. So on the left is a typical visitor hallway. On the right is what we'll call a bypass hallway. And the patients go in and out in this hallway. Logistics goes in and out in the hallway. The patient could get in and out without engaging with their family members. It could be very private and done well. So the bypass hallway enhances patient privacy by providing a private corridor for patient transport in and out of the unit. Minimizes patient contact and disturbance by visitors that are hanging over the patient transport bed. If any of you work in units where the waiting room is right by the entrance to the ICU, you'll see the bed rolling in, the nurses, respiratory therapists trying to ventilate the patient, move things along, and the families just simply getting in the way, destroying privacy and decreasing patient safety. And finally, it eliminates contact of visitors with the logistic deliveries and movement of various big, heavy diagnostic technologies. Let's get back to our friends, the staff. Well, they have to have proper lounge and work areas. So we're back in Holland. This is the staff lounge. This is the most impressive lounge I've ever seen. To the left is a balcony. Remember, they're on the roof. Deep in this picture is their food court with refrigerators, microwaves, and places for families to sit. We have everything in New York except for the area outdoors. We have windows. You can look at the 59th Street Bridge. But it is very important for the ICU to have a staff lounge that is fully engageable, that the staff wants to go to in their downtime. They don't want to run out of the unit. And it gives them everything they need for some serenity in between patient care. Let's move on to the patient room. So we're in the room, and we have all kinds of staff, others, what I call ICU voyeurs, looking into the rooms, and we have to apply privacy. The typical privacy applied are curtains. Curtains should be eliminated. Curtains have to be rehung in between patients. They get dirty, they get infected, they're a mess. So the other approach would be e-glass. And let's go back to Holland. So here we have huge glass. You push a button and the glass goes opaque. You push a button, the glass goes clear. We're now on our second generation of e-glass at Memorial. You need to take out a long-term warranty on this stuff. I didn't know that when we started. Nobody did. It was 06 who knew all the technicalities. But we subsequently learned it's a fancy technology. Is it expensive? It's expensive to install. It is not expensive to run and maintain. And we've learned a lot as we've gone on with this technology. Our new emergency room wing of 23-hour observation, all is e-glass, and we've learned as we've gone on. Let's get into the patient room itself, focusing on family areas. So the center of the patient room is always the ICU bed. This is the cornerstone of the room. And then we have other work areas. And if we look at the orange areas on both sides, this is a family zone. This is a virtual family zone. Chairs could be moved anywhere in the patient room. More importantly, it would be great if we could have a family zone like the green zone on the right, where a fixed family zone with a bed, a couch, refrigerator, computer, reading desk, a sink, whatever is necessary. So let's go to Emory University Neuroscience Unit, also a unit built on a rooftop. And in this unit, we're looking at their typical room schematic, looking down into the room. This is the hallway to the right. This is the patient area in the center, and to the left is a patient family member zone. These are couches that come out. We have a TV, we have a refrigerator, we have a sink, we have a desk. This is awesome. Let's get back into the room itself. The ideal room would have no junk on the floor, no ventilators, no poles, no pneumatic compression boots, no nothing. So everything really should be on booms, ideally, or certainly fixed columns to get the floor clean. So in this schematic, this is typical fixed column area, stuff all over, patient wrapped up in what we affectionately call spaghetti. And you want to get other people into the room. It's hard to get to the patient. It's hard for family to get to the patient. So there has to be a different way to do things, and that is to get rid of all the fixed columns, and instead we put in booms. Booms are otherwise known as mobile articulating columns. Yes, it is a little more expensive than the fixed setup or the head wall, but it's well worth it. Here, all the equipment is on the booms, and the booms can be directed in any which way. One can intubate a patient, put lines in a patient, sono the patient, whatever. We could get to the patient easily, and we could turn the patient around, face the window, get a little sunlight, always very nice, and family members could get to the patient as well. In Memorial, because we're poor, we only had 2 booms. The Utrecht ICU went crazy. This place, they really have 4 booms. I'm just photographing 3 of them. Everything went on the boom here. The monitoring, the ventilator, the pumps, the computer for the nurse to interact, dialysis areas, dialysis plumbing, as well as another boom for television entertainment. It was really awesome. So you get to the patient, family get to the patient, and it's a much cleaner room to work in. What about the room's environment itself? room could be very noisy. So we have staff talking too loudly. We have monitors, pumps, ventilators, all making a lot of unnecessary, useless noise. And we can, in fact, put sound sensors in the room. I'll show you a version of that. And we can have sound sensors that reach out and tell staff that room is getting really noisy, please do something about it. Alternatively, we could put some high-tech systems in that move the alarms to various handhelds, communication between staff through earpieces and small mics, and we can have sound masking in the room. So there's certainly things we could do. The other thing that bothers patients, so if you've ever been a patient in a hospital, one of the things that make you crazy is glare from the sun coming in the room. So the room has to think about a design that cuts glare. So we can have a shade, nice approach, blinds, or e-glass in the outside window. So we're in the process now of electrifying all our shades that the patient or staff could control it off a little device at the bedside. What about lighting within the room? You need to have multi-level lighting to provide a comfortable environment. So you need bright light, subdued light, night light, and so on. All these things need to be thought about as you're designing or rehabilitating an intensive care unit. This device is called the IC Sentinel by Oberon, and it's in fact a multi-sensor system. What's pertinent to this discussion is it measures light and sound, and we've outfitted several of our rooms and the nursing stations right outside the rooms to keep track of sound and light. And we're identifying the times of the day or night when sound and light is both inappropriate and out of control, and then we can enact database interventions to fix this up. And the software of the system, here is a 24-hour period on the x-axis, sound in decibels on the y-axis, and one could track when the sound is getting very high. Commonly, ICU staff members in the room at the nursing stations are not really cognizant of how much noise they make, especially at night. So that's another thing to be tuned in. Serenity and entertainment. So we can have regular artwork in the rooms, we can have video artwork. In fact, the same vendor that built that digital cinema builds it for the ceiling as well. And this has been installed in ERs and in CAT scan rooms and cardiac cath rooms. Certainly could be put into an ICU as well, as long as you're knowledgeable about it. We have looked at various sound systems in the room, sound systems on the bed. Many of the new ICU beds come with sound systems, and TVs and other abilities. The patient may have an iPhone or a Droid with their own music. So we're at this point installing, as we speak, Bluetooth speakers on the booms in every ICU room, and the patient with his or her iPhone, Droid, whatever, can pump their own music in. At the same time, we have a project where we're putting iPad minis in every room, and we're configuring them now, and this will be patient agnostic. No private information will go in. It will be locked down, but it will provide all kinds of entertainment and other types of apps for the patient, notably communication apps. Bringing order to disorder, and we'll finish with this. So there's a lot of disorder that can occur in the room. I just want to focus on language disorder. So in New York, you used to have to know a little English and a lot of Spanish. Today, you actually have to know a lot of Russian, because the population is shifting, and a lot of Mandarin, and we are rusty in that. So it's very important to provide high-tech translating systems in the rooms themselves, both for the patients and for the families, and otherwise everybody flips out. So we have carts that come in the room with video connectivity 24/7 to translators from somewhere in the middle of America that track about 20 languages 24/7 and add in other languages by appointment as needed. So in conclusion, patient-centered care is the ultimate goal of ICU care. Purposeful design and the targeted application of technologies are vital steps in the patient care-centered process. caring for the staff, in addition to the patient and family, will help optimize patient-centered care for all. Thank you very much.